Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Welcome, future nurses, to another important part of our journey in client care. We are uploading daily 2 to 3 videos of different topics. Today we turn our focus to one of the body's largest and most protective organs, the skin and its related structures. The skin is not just a covering, it is the first line of defense against infection, a regulator of body temperature, and a mirror that often reflects underlying health conditions. Disorders of the skin, hair, and nails are not only common, but can also significantly affect a client's physical comfort, emotional well-being, and quality of life. In this session, we will explore the essential nursing care principles for clients with skin disorders. We will learn how to assess, plan, and provide interventions for conditions ranging from minor irritations to serious dermatologic diseases. We will also highlight the importance of prevention, infection control, wound management, and client education. By the end of this section, you will be equipped with the knowledge and confidence to provide safe, compassionate, and effective care for clients facing these challenges. Before starting this question session, I want to tell you something. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exam successfully. What makes it different? It's an all-in-one package, designed to cover every part of your NCLEX prep. Interactive live classes and easy to watch. Recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks, and on PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail. During comprehensive lecture, this isn't just another review, it's everything you need in one. Please scan the QR code right now, or use the link in the description to enroll instantly, and grab free content, including PDF notes, practice tests, and NCLEX quizzes you'll also get. Let us begin the script with a critical emergency scenario that often appears in both practice and real life. Imagine a community health nurse witnessing an individual rushing out of a burning house while flames are actively consuming their clothing. Several bystanders rush forward, attempting to pour cold water and apply ointments directly onto the burns. At this moment, the nurse must decide on the most immediate and life-saving intervention. Here are the options. Option 1 is to rub petroleum jelly over the visible burned skin to protect the tissue. Option 2 is to wrap the client's body with a clean, dry cloth to cover the burns. Option 3 is to apply ice packs directly to the burned areas to minimize tissue damage. Option 4 is to roll the client on the ground or cover them with a heavy blanket to extinguish the flames. The correct answer is Option 4, roll the client on the ground or cover them with a heavy blanket to extinguish the flames. Now, let us carefully walk through the reasoning behind this decision. The immediate and most critical priority in burn emergencies is to stop the burning process itself. As long as flames remain active, tissue destruction continues, and the client is at risk for airway compromise from inhalation injury. Rolling the victim on the ground or smothering the flames with a blanket effectively removes oxygen from the fire, halting further thermal injury and preventing the burn from deepening. This aligns with the American Burn Association's first aid sequence. Stop the burning, remove smoldering clothing and jewelry, cool with water, cover with a clean cloth, and transport for definitive care. Turning now to the incorrect options, rubbing petroleum jelly over the burned skin may sound soothing, but in reality, it traps heat inside the tissue, increases the risk of infection, and interferes with accurate burn assessment once medical care begins. This practice is outdated and unsafe. Wrapping the client with a clean cloth is indeed an essential step in later management, but it must never be done while flames are still present because it can trap heat and oxygen, making the fire worse. Similarly, applying ice directly to burns is dangerous. Ice causes vasoconstriction, worsens tissue ischemia, and can lead to additional frostbite-like injury. In large burns, it can also trigger hypothermia, raising mortality risk. Only cool running water should be used once the flames have been extinguished, never ice. Here are the clinical insights and exam strategies to remember. The first priority in burn emergencies is always to stop the burning process before anything else. Nurses must also recognize and avoid common myths, such as applying petroleum jelly, toothpaste, butter, or ice, all of which worsen burns. A helpful memory trick for the correct sequence is stop, cool, cover, transport, which reflects the gold standard in pre-hospital burn management. For NCLEX preparation, always look for the action that prevents further injury and aligns with safety first principles, even if other options appear helpful. And here's the Stancoast Pearl. When fire is present, the nurse's hands are not for ointments or ice, they are for action. Extinguish flames first, then cool and cover. Only after the hazard is gone can true healing begin. Let us dive into our next critical NCLEX scenario, with a case that often challenges even the most experienced nurses. A nurse in the emergency department is assessing a victim of a house fire who presents with deep, partial thickness burns to the anterior chest and neck. The client is alert, oriented, and complaining of pain, but has hoarseness in the voice and singed nasal hairs. The question is, which nursing action is the highest priority at this time? Here are the options to consider. Option A, obtain the client's pulse and blood pressure. Option B, monitor the client for respiratory distress. Option C, identify the client's next of kin. Option D, determine the total body surface area of the burn injury. The correct answer is option B, monitor the client for respiratory distress. This is because airway protection is always the first priority in clients with burns to the face, chest, or neck. Hoarseness and singed nasal hairs are classic red flag signs of inhalation injury. And even though the client is talking now, airway swelling can progress rapidly, sometimes within minutes, by monitoring closely for stridor, worsening hoarseness, tachypnea, drooling, or use of accessory muscles. The nurse ensures that life-saving interventions like early intubation can be initiated before the airway closes. According to the ABCs of emergency care, airway always comes before circulation, disability, or any secondary assessments. On the other hand, let us look at why the other options are incorrect. Option A, obtaining the client's pulse and blood pressure, is important for identifying fluid loss or shock, but hypovolemic shock typically occurs later, while airway compromise can be fatal much sooner. Option C, identifying the client's next of kin, may be important for legal and emotional reasons, but psychosocial needs come after immediate survival in both the ABC framework and Maslow's hierarchy. Option D, determining the total body surface area of the burn injury, is necessary for calculating fluid resuscitation using the Parkland formula, but this calculation is meaningless if the client's airway becomes obstructed before interventions can even begin. To make this clinically high yield, remember these insights. Airway must always be anticipated as the first risk in facial or chest burns. Signs like hoarseness, singed nasal hair, or carbonaceous sputum require immediate attention, and nurses should anticipate the need for early intubation before edema makes it impossible. When using priority frameworks such as ABCS, Maslow's hierarchy, and safety or risk reduction, airway protection will always rank higher than circulation or documentation tasks. Stancoast. Pearl, in burn emergencies, the airway is the most fragile thread. It can close silently and swiftly. Protecting it comes before every calculation, assessment, or phone call. Let us start this scenario with a life-threatening emergency that really tests your ability to prioritize nursing actions. A client is rushed to the emergency department after a devastating house fire and presents with deep partial thickness and full thickness burns across the chest, upper extremities, and interior neck. The client is awake but in severe pain, and you immediately notice hoarseness of voice and singed nasal hairs, which are red flag signs of possible inhalation injury. The question asks, which immediate nursing interventions are most appropriate for this client? The options are as follows. Option 1, place ice packs directly on the burned areas. Option 2, pour normal saline over the wounds before dressing care. Option 3, initiate rapid intravenous infusion of lactated Ringer's solution. Option 4, administer tetanus prophylaxis. Option 5, provide intravenous opioid analgesics for pain control. And option 6, administer humidified oxygen therapy. Now the correct answers are options 3, 4, 5, and 6. Let me explain why. Beginning with option 1, placing ice packs directly on the burned areas is incorrect. While minor burns may briefly benefit from cool water, direct ice application is dangerous in major burns because it worsens vasoconstriction, reduces blood flow to already injured tissue, and increases the risk of hypothermia when large areas are involved. Moving on to option 2, pouring normal saline over the wounds before dressing care is also incorrect at this stage. The priority in the emergency phase is not cleansing the wounds, but stabilizing airway, breathing, and circulation. Pouring saline on extensive burns can worsen heat loss and lead to hypothermia, making this step inappropriate during initial resuscitation. In contrast, option 3, initiating rapid intravenous infusion of lactated Ringer's solution, is absolutely correct. Large burn injuries cause profound fluid shifts that can rapidly lead to hypovolemic shock. Lactated Ringer's solution is the fluid of choice because its composition closely resembles plasma and helps prevent metabolic acidosis. The Parkland formula guides how much fluid is needed, and urine output monitoring is the best indicator of adequate resuscitation. Next, option 4, administering tetanus prophylaxis, is another correct action. Burn wounds are highly prone to contamination with Clostridium tetani spores, and prophylaxis is essential if immunization status is unknown or outdated. Continuing with option 5, providing intravenous opioid analgesics is also correct. Severe burn pain triggers a massive stress response, and intravenous administration ensures reliable absorption when peripheral perfusion is compromised. Adequate pain control not only reduces suffering, but also allows the client to tolerate further procedures such as intubation or wound care. Finally, option 6, administering humidified oxygen therapy, is correct and arguably the first priority. With facial and neck burns, the risk of airway swelling and obstruction is extremely high. Hoarseness and singed nasal hairs are classic clues of inhalation injury. Oxygen administration immediately improves oxygenation and prepares the client in case early intubation is needed to secure the airway. To summarize the clinical reasoning, always remember the ABCDE approach. Airway and breathing come first, followed by circulation, disability, and exposure. For this client, oxygen therapy protects the airway, fluid resuscitation prevents shock, analgesia reduces the stress response, and tetanus prophylaxis reduces infection risk. Local wound care like saline irrigation or ice application is not part of the immediate stabilization and may actually cause harm. Here is the Stancoast Pearl for this scenario. Burn management is not about treating the skin first, it is about protecting life. Always prioritize airway before wounds and circulation before dressings. Oxygen, fluids, analgesia, and tetanus prophylaxis save lives, while ice and saline irrigation can delay critical stabilization. Let us now dive into another high-yield NCLEX question that really challenges your ability to distinguish the different burn depths. A client is rushed to the emergency department after surviving a severe house fire with deep partial thickness and full thickness burns covering 35% of the upper body. During the nurse's assessment, documentation of the full thickness areas is required. The question asks, which description most accurately reflects the expected appearance of these full thickness burns? Here are the options to consider. Option 1, white and leathery. Option 2, pink and blistered. Option 3, red and painful. And option 4, mottled and wet. The correct answer is option 1, white and leathery. Full thickness burns extend through the epidermis, dermis, and even into the subcutaneous tissues. Because the dermal nerve endings are destroyed, the burned area itself is often insensate, meaning it does not hurt. Although surrounding partial thickness burns may still cause significant pain, the hallmark appearance is pale, white, tan, brown, or even black, with a dry, leathery texture. Capillary refill is absent, blanching is not seen, and healing will not occur spontaneously. Grafting is required. Moving on to option 2, pink and blistered. This is incorrect because it actually describes superficial partial thickness burns. These involve the epidermis and the upper dermis, appear moist, red or pink, and are very painful due to exposed nerve endings. They commonly blister, heal within 10 to 21 days, and typically leave minimal scarring, quite different from the leathery, insensate appearance of full-thickness burns. Now considering option 3, red and painful. This choice is also incorrect as it reflects the features of superficial or first-degree burns, such as a sunburn. These burns are limited to the epidermis, presenting with redness, hypersensitivity, intact capillary refill, and no blistering. They heal within 3 to 7 days without scarring, making them much more superficial than full-thickness burns. Finally, let us analyze option 4, mottled and wet. This is not correct either, because this description corresponds to deep, partial thickness burns. These burns extend deeper into the dermis, leading to areas of mottling with sluggish capillary refill, a moist or wet surface, and persistent pain because some nerve endings survive. Healing is prolonged, often more than 3 weeks, and scarring is common. Here is the clinical pearl to remember. Painful burns are not always the deepest. Full-thickness burns paradoxically appear calm and insensate, white, pale, and leathery, while the surrounding partial thickness burns are the ones causing excruciating pain. This paradox is key for correct identification, guiding nursing actions such as fluid resuscitation, escharotomy, and surgical planning. Let us move smoothly into a high-yield NCLEX-style scenario that focuses on burn management and fluid resuscitation. A client with extensive thermal burns has undergone the initial phase of resuscitation with large volume fluid replacement. After stabilization of blood pressure, the nurse must now determine whether the client is responding appropriately to therapy. The question asks, which clinical assessment finding provides the most reliable indicator of adequate fluid resuscitation during the acute phase of burn management? The options to consider are normal body temperature, minimal level of pain, adequate urine output, and ability to perform exercises. The correct answer here is option 3, adequate urine output. To understand why this is correct, let us walk through the clinical reasoning step by step. The very first life-threatening complication after a major burn is hypovolemic shock. This is triggered by a massive fluid shift out of the blood vessels into the tissues because of increased capillary permeability, a process that starts within minutes and peaks at 24 hours after injury. This is why burn resuscitation protocols such as the Parkland formula emphasize rapid and aggressive intravenous fluid replacement to restore circulating volume, protect vital organs, and prevent multi-organ failure. Now, the key point to remember is that urine output is the gold standard for assessing the adequacy of fluid resuscitation. Unlike blood pressure or heart rate, which can fluctuate for many reasons, urine output directly reflects renal perfusion and cardiac output. For adults, the goal is 0.5 to 1 milliliter per kilogram per hour, which translates to about 30 to 50 milliliters per hour. If this target is consistently achieved, it confirms that resuscitation is effective and that the kidneys are being perfused adequately. On the other hand, low urine output is an early red flag for under-resuscitation, while excessive output may suggest over-resuscitation and fluid overload. Looking at the incorrect options helps reinforce this concept. Normal body temperature is not reliable here because thermoregulation is impaired after burns. Clients may develop hypothermia early on or fever later due to infection or systemic inflammation, but this does not reflect fluid status. Minimal pain is also not dependable because pain intensity is determined by the depth of the burn. For example, clients with partial thickness burns may experience severe pain, while those with full thickness burns often feel very little pain due to destruction of nerve endings. Similarly, the ability to perform exercises may become important later for preventing contractures, but it does not indicate whether resuscitation has been successful during the acute phase. Here are the clinical pearls to lock this into memory. The very first priority after a burn is preventing hypovolemic shock, and urine output is the most sensitive and reliable marker of effective resuscitation. Aim to maintain 0.5 to 1 milliliter per kilogram per hour in adults. Do not forget that hypotension and tachycardia appear late, while urine output falls much earlier, making it the best early warning sign. And here is the Stankos pearl for you. In burn management, the kidneys tell the truth. A steady urine stream means the fluids are reaching where they need to go. Let us move smoothly into our next NCLEX-style practice scenario, one that highlights a critical concept in burn management. Imagine a client with partial and full thickness burns over the interior chest and upper extremities, who is being treated with the open exposure method. In this approach, the wound is carefully cleansed, covered with a topical antimicrobial agent, and then left uncovered without a dressing. Now, as the nurse continues with this client's plan of care, the key question becomes, which complication should be the priority focus for monitoring under this treatment approach? Here are the options. Option A, infection. Option B, hyperthermia. Option C, depression. And option D, malnutrition. The correct answer is option A, infection. Let us walk through the reasoning behind this. Burn management typically relies on either the closed method, where antimicrobial creams are covered with sterile dressings, or the open method, where the wound is left exposed to air. While the open exposure method may be useful for areas such as the face or other regions where dressings are impractical, it does create a significant risk. That risk is infection. Burn injuries strip away the protective skin barrier, leaving the body vulnerable to invasion by microorganisms. In an uncovered wound, pathogens from the environment, healthcare staff, and even the client's own respiratory or gastrointestinal flora can easily colonize the burn tissue. The Shear itself provides a nutrient-rich surface for bacterial growth, making infection the leading cause of morbidity and mortality in burn patients after stabilization. Nurses must watch for red flags such as purulent drainage, changes in wound appearance, foul odor, fever, leukocytosis, and signs of sepsis. Turning to option B, hyperthermia, it may seem possible because of the hypermetabolic state that burn clients develop, but in the specific context of open exposure therapy, hypothermia is more likely. The exposed surface loses heat rapidly through evaporation, increasing the danger of cooling rather than overheating. Option C, depression, is also an important consideration, as burn survivors face pain, altered body image, and functional loss. However, depression is not specific to this method and is not immediately life-threatening. Finally, option D, malnutrition, is a significant challenge because burn clients enter a hypermetabolic state that demands enormous caloric and protein intake to support healing. Still, this problem applies to all burn clients regardless of wound care approach. Infection stands apart because it is both a direct and urgent threat associated with the open method. From a nursing perspective, the priority actions include maintaining strict hand hygiene, applying topical agents using sterile technique, and initiating reverse isolation when needed. Nurses must also monitor wound cultures, vital signs, and systemic changes that could indicate septicemia. Education is essential as well. Clients and families must understand that contact with the exposed wound should be minimized, and infection control practices must be followed rigorously. Here is the Stancoast Pearl to lock this in. In burn care, infection is the enemy. When the skin barrier is gone, the wound becomes an open door. The open exposure method magnifies this risk, making infection surveillance the nurse's #1 priority. Let us now move into another advanced NCLEX practice scenario to sharpen your understanding of burn care. Imagine a nurse is caring for a client with deep, partial, and full thickness burns across the anterior trunk. The provider has prescribed topical Mafenide acetate, also known as sulfamylon, to be applied directly to the wound bed. The question asks, which nursing consideration reflects the most significant disadvantage of this therapy? Here are the options to consider. Option A is skin discoloration. Option B is intense pain on application. Option C is unpleasant odor. And option D is contact dermatitis. The correct answer here is option B, intense pain on application. Let us carefully break this down so that the reasoning becomes clear. Mafenide acetate is a potent antimicrobial agent that works by inhibiting carbonic anhydrase and exerting both bacteriostatic and bactericidal activity against a wide range of organisms, including the difficult-to-treat Pseudomonas aeruginosa. Unlike silver sulfatazine, which soothes the skin with a cooling effect, Mafenide acetate penetrates deeply through Shear into viable tissues, directly stimulating exposed nerve endings. This deep penetration is why it is so effective in reducing infection risk, but also why it causes such intense burning pain when applied. In fact, the pain can be so severe that clients often require pre-medication with analgesics before application. To put this into perspective, other topical agents have different drawbacks. Silver nitrate, for instance, is notorious for staining everything it touches and can cause electrolyte imbalances. Silver sulfatazine, on the other hand, is painless and soothing, but it does not penetrate Shear well and may lead to leukopenia or localized dermatitis. Mafenide's unique problem, however, is its painful application and the risk of systemic metabolic acidosis because of its carbonic anhydrase inhibition, which may reduce renal bicarbonate reabsorption. This is why nurses must monitor arterial blood gases, observe for signs such as tachypnea or confusion, and closely track electrolytes during treatment. Now let us analyze the incorrect options. Option A, skin discoloration, is incorrect because this is not a common outcome with mafenide acetate. Instead, silver nitrate is the agent that leaves behind significant stains on skin and linens. Option C, unpleasant odor, is not associated with mafenide, as it has no characteristic odor. Any mild odor is usually seen with silver sulfadiazine. Option D, contact dermatitis, is not a hallmark of mafenide either, but rather a side effect that may appear with silver sulfadiazine. This makes option B the most accurate answer. From a nursing care standpoint, the implications are critical. The nurse must prepare the client by explaining that pain is expected, administer prescribed analgesics before applying the cream, and continuously assess pain after treatment. Monitoring for systemic acidosis is also a vital responsibility, and educating clients about why this medication is still chosen, despite the pain, helps build trust and compliance. Here's the Stancoast Pearl. Mafenide acetate digs deep to kill bacteria under the burn, but it burns the patient back with pain and acidosis risk. Always balance infection control with client comfort and safety. Let us now walk through this NCLEX-style burn care scenario in a smooth narrative so that it flows well for a video script. A client with deep partial and full thickness burns is scheduled for hydrotherapy debridement, and the nurse must decide what action is most critical just before the procedure. Here are the options to consider. Option A suggests maintaining the client in a fasting state to prevent aspiration. Option B points to ensuring that a signed consent form is available on the chart. Option C highlights administering the prescribed analgesic at the appropriate time. Finally, Option D focuses on weighing the client on a bed scale to monitor fluid status. The correct answer here is Option C, administering the prescribed analgesic at the appropriate time. Now, let us carefully reason this out. Hydrotherapy debridement is a painful procedure where necrotic tissue and debris are mechanically removed, often with whirlpool immersion or shower techniques. Because nerve endings are exposed in burn tissue, clients experience extreme discomfort, and failing to provide adequate pain relief can lead to sympathetic overdrive with tachycardia, hypertension, and metabolic stress, which may further destabilize an already vulnerable burn client. By administering opioids such as morphine, fentanyl, or hydromorphone around 30 to 45 minutes before the session, the nurse ensures that peak pain relief coincides with the most painful parts of the procedure. Sometimes anxiolytics are added to reduce fear and prevent anticipatory anxiety. Effective pain control improves tolerance, reduces psychological trauma, and prevents complications. For this reason, analgesia is the immediate and critical intervention. Turning to the other options, fasting as an option A is not required because hydrotherapy is not performed under general anesthesia. Clients can eat and drink as tolerated unless they are scheduled for operative debridement under anesthesia. Option B, ensuring a consent form, is important for surgical procedures such as grafting but is not required for routine wound care like hydrotherapy. Option D, weighing the client, is certainly necessary for fluid balance and nutritional monitoring in burn care, but it is not directly linked to client safety during the procedure itself and can be performed at another time. Therefore, while all of these actions have relevance in the larger context of burn management, they are not the most immediate priority before hydrotherapy begins. To summarize with high yield points for NCLEX preparation, pain management always comes first before burn wound care. Hydrotherapy reduces bacterial load and prepares wounds for grafting but carries risks like pain, hypothermia, and contamination, and Maslow's hierarchy reminds us that physiologic stability, in this case pain relief, overrides routine tasks or legal documentation in this specific moment. Exam strategy-wise, when faced with several reasonable nursing actions, prioritize the one that directly protects the client's safety and procedural tolerance. And here is your Stancoast Pearl. Burn wound debridement is not just routine care, it is an intense pain event. The nurse's ability to anticipate and manage that pain is what transforms the experience from potential trauma into therapeutic healing. Let us now move into another advanced NCLEX-style scenario that highlights critical thinking in burn care, Imagine a client with extensive full-thickness burns who has undergone autologous skin grafting to promote wound closure and decrease the risk of infection. During the immediate postoperative period, the nurse is developing a care plan to protect graft viability, and the question becomes, which nursing intervention should be prioritized to optimize graft adherence and survival? Here are the options to consider. Option A suggests minimizing movement of the grafted area to prevent disruption. Option B recommends changing the dressing over the graft every 8 hours to maintain wound hygiene. Option C proposes reinforcing the graft dressing if serosanguinous drainage is noted. Finally, Option D advises applying wet saline soaks to the graft site every 4 hours to prevent drying. The correct answer here is Option A, minimizing movement of the grafted area to prevent disruption. Let me explain why this is the best choice. The first 48 to 72 hours following skin grafting are the most critical, because the graft undergoes revascularization, beginning with plasmatic imbibition, followed by inosculation, and then capillary ingrowth. Any shearing force, pressure, or movement can disrupt these delicate vascular connections and cause partial or total graft failure. Immobilization through splints, elevation, or strict bed rest ensures that the graft adheres properly, reducing the risk of hematoma, seroma, or infection. Protecting graft stability during this period is absolutely life-saving. Now let us turn to the incorrect options to understand why they should not be chosen. Option B, changing the dressing every 8 hours, is contraindicated because graft dressings are intentionally left undisturbed for at least 3 to 5 days to allow adherence. Removing or replacing them too soon risks dislodging the graft and exposing it to infection. Option C, reinforcing the graft dressing if drainage occurs, may seem appropriate, but in reality, significant drainage or hematoma beneath the graft must be reported immediately to the surgeon, since surgical intervention may be required to save the graft. Simply reinforcing the dressing can delay life-saving care. Option D, applying wet saline soaks every 4 hours, is appropriate for donor sites but not for graft sites. Wet dressings promote bacterial growth and maceration, weakening adherence and threatening graft viability. To solidify this with high-yield NCLEX points, remember the phases of graft healing: plasmatic imbibition within the first 24 to 48 hours, inosculation around 48 to 72 hours, and complete revascularization thereafter. The graft must remain immobilized throughout this time, with the first dressing change only performed by the surgeon. Nurses should monitor for foul odor, drainage, or signs of infection without disturbing the graft. In contrast, donor sites are managed with moist dressings to promote epithelialization. Here is your NCLEX tip. When prioritizing burn graft care, always choose the option that prevents shear, contamination, or disruption of fragile vascular connections, because graft protection is the key to survival. Let us transition into a crucial discharge teaching scenario for burn rehabilitation. Imagine a client who has survived extensive third-degree burns and is now being fitted for a customized elasticized pressure garment before going home. The nurse explains the importance of this garment, and the question becomes, which client statement best shows accurate understanding of its purpose? Here are the possible responses. Option A is, it will keep me from developing another infection in the burn area. Option B says, it is mainly to protect my skin from exposure to the sun. Option C states, it will help reduce the thickness and severity of scar tissue. And Option D remarks, it will prevent people from rejecting me socially. The correct answer is Option C, it will help reduce the thickness and severity of scar tissue. This is because pressure garments are an essential tool in long-term burn rehabilitation. By applying consistent, gentle pressure across healing skin, they guide collagen fibers to align in a more organized, parallel manner. This prevents the irregular, raised bundles typical of hypertrophic or keloid scars. As a result, scarring is flatter, more flexible, and less likely to cause contractures that would otherwise restrict movement. These garments are typically worn 23 hours a day for 12 to 24 months, or until scar tissue matures. And research shows they also help reduce redness, swelling, and itching during recovery. Now, why are the other options not correct? Beginning with Option A, the idea that the garment prevents infection is a misunderstanding. Once the wounds are healed or grafted, infection risks decrease significantly, and the garment itself does not function as a microbial barrier. Moving to Option B, while it is true that burn survivors must protect fragile new skin from sunlight, the garment was not designed for ultraviolet protection. sunscreen, hats, and protective clothing are the proper preventive measures for sun-related damage. Shifting to option D, although the smoother cosmetic results of pressure garments can indeed support self-esteem and reduce feelings of stigma, preventing social rejection is not their primary role. Social reintegration requires broader support such as counseling, rehabilitation programs, and peer support groups. Here are the high-yield pearls to remember. Pressure therapy prevents thick, raised scars and limits contracture development by remodeling collagen. Garments must be worn nearly all day for 1 to 2 years to be effective. Nurses must emphasize correct fit, adherence, skin checks for breakdown, and emotional coping strategies to increase compliance. Finally, psychosocial support remains vital because burn survivors often struggle with body image concerns and depression. Stand Coast, Pearl. Think of pressure garments as a gentle sculptor, working silently and constantly to shape collagen into smoother, functional skin that restores both appearance and movement. Shifting our focus to an emergency care situation, imagine a 32-year-old construction worker who has just sustained a high-voltage electrical injury and is rushed to the emergency department. As the nurse begins the initial assessment, the question arises, which findings should be considered the top priority during the physical examination? Here are the options. Option A is the entry and exit wound sites. Option B is the degree of skin discoloration around the burn. Option C is the amount of eschar present on the wound bed. And option D is the characteristics of serous or bloody wound drainage. The correct answer is option A, the entry and exit wound sites. The reason this assessment takes precedence is because electrical burns are unlike other burns. The real destruction usually happens deep inside along the current's pathway, not just at the skin level. Identifying the entry and exit sites allows the nurse to trace where the current traveled. If the current ran from hand to foot, it could have crossed the heart, predisposing the patient to fatal arrhythmias. If it went across the skull, it might have caused brain injury. Typically, the entry wound looks small, charred, and depressed, while the exit wound is more explosive in appearance. Recognizing these sites immediately guides the nurse to anticipate life-threatening complications like cardiac dysrhythmias, rhabdomyolysis, with myoglobinuria, acute kidney failure, and compartment syndrome. Looking at the incorrect responses helps reinforce this concept. Option B, the degree of skin discoloration only reflects superficial damage. Electrical current can leave skin changes minimal, while severe necrosis rages beneath the surface. Option C, the amount of eschar, is critical for thermal burns, where tight eschar can cut off circulation. But in electrical injuries, eschar is not the first indicator of danger. Option D, the characteristics of wound drainage may matter later for infection monitoring, but in the emergency phase, it does not provide life-saving information. Here are the NCLEX pearls to cement your learning. Think past what you see. Electrical burns often hide more than they show. Always place the patient on continuous cardiac monitoring because the conduction system is at risk. Anticipate rhabdomyolysis, which can clog the kidneys with myoglobin, and manage with intravenous fluids and urine alkalinization. And finally, never forget that circulation in electrical burns is not only about blood loss, it is also about rhythm stability in the heart. Shifting our attention to one of the most fundamental areas of nursing care, let us talk about preventing pressure ulcers in immobile clients. A nurse is developing a care plan for an immobile client who is at high risk for pressure ulcer development. Based on the nurse's understanding of the pathophysiology of pressure injuries, which intervention should take priority to maintain skin integrity? Here are the options. Option A is to apply a skin toughening agent to vulnerable areas. Option B is to massage reddened skin that does not blanch under pressure. Option C is to maintain the head of the bed elevated at 30 degrees. And option D is to reposition the client at least every 2 hours. The correct answer is option D, reposition the client at least every 2 hours. Now, moving deeper into the reasoning, repositioning is the single most effective and evidence-based nursing intervention to prevent pressure ulcer formation. Pressure ulcers are caused by unrelieved pressure over bony prominences that cuts off capillary blood flow. When the external force exceeds the capillary closing pressure of about 32 millimeters of mercury for too long, tissues become ischemic and necrotic. By turning the client every 2 hours, the nurse relieves this pressure, restores circulation, and minimizes shear and friction forces. This action also promotes lymphatic drainage, reduces the buildup of metabolic waste, and aligns with National Pressure Injury Advisory Panel guidelines, that emphasize repositioning as the cornerstone of prevention. Immobile clients are especially vulnerable because they may also have impaired sensation, poor nutrition, or moisture exposure. So schedule turning is absolutely essential. Looking at the incorrect choices, applying a skin toughening agent, option A, might reduce moisture damage, but it does not address the real problem, which is unrelieved pressure. It creates a false sense of protection without truly preventing ischemia. Massaging reddened skin that does not blanch, option B, is actually harmful. Non-blanchable redness is the first sign of tissue injury, and massage increases friction and heat, worsening damage. Clinical guidelines warn against this practice, maintaining the head of the bed elevated at 30 degrees. Option C may reduce aspiration risk in some clients, but it increases shear forces on the sacrum and heels, putting the skin at greater risk of breakdown. While this position has its uses, it cannot replace repositioning. Here are some clinical pearls to carry with you. The pathophysiology of pressure ulcers is always about prolonged pressure causing ischemia and necrosis. Key risk factors include immobility, incontinence, poor nutrition, advanced age, and neurologic impairment. The prevention hierarchy begins with repositioning, followed by support surfaces, moisture and nutrition management, and finally, topical skin protection. For NCLEX strategy, always choose the intervention that removes the underlying cause, in this case, relieving pressure. Stand-coast. Pearl. Pressure ulcers are not caused by fragile skin, they are caused by unrelieved pressure. Repositioning is the reset button that restores blood flow, prevents ischemia, and protects skin integrity. As we continue building your NCLEX mastery, let us turn our focus to a very common challenge in immobile elderly patients. Imagine an 82-year-old bedridden client who is frequently observed sliding down toward the foot of the hospital bed, with the heels and sacrum pressing into the mattress, while the skin of the back is being pulled in the opposite direction. The nurse must determine what type of skin injury this client is at greatest risk for. Here are the options. Option A is injury caused by continuous unrelieved pressure. Option B is injury caused by shearing force between the skin and deeper tissues. Option C is injury caused by friction of the skin surface against linens. And option D is injury caused by agitation and frequent movement in bed. The correct answer is option B, injury caused by shearing force between the skin and deeper tissues. Shearing occurs when the skin stays relatively fixed against the bed sheets, while the skeleton and deeper tissues slide downward. This stretches and tears fragile blood vessels in the subcutaneous tissue, leading to deep tissue injury. In elderly clients with fragile skin and reduced perfusion, shear is especially dangerous because the damage often begins beneath the surface and can rapidly progress to full-thickness pressure ulcers if not addressed. Unlike pure pressure injuries, which happen when capillary closing pressure of about 32 millimeters of mercury is exceeded, shear disrupts circulation from inside, making it more insidious. Now, let us break down the incorrect answers. Option A, continuous pressure, is incorrect, because although pressure ulcers are common in immobile patients, the scenario here specifically describes sliding downward, a hallmark of shear, not just vertical compression. Option C, friction, is also incorrect because friction causes superficial abrasions or blisters when surfaces rub directly against each other, such as dragging a patient without a draw sheet. This does not explain the deeper injury described. Option D, agitation in bed, is not the answer either, since voluntary restlessness may cause rubbing but does not create the repeated downward sliding forces of shear. Here is your stand-coast pearl. Shear is the hidden culprit behind many deep tissue injuries, unseen on the surface but devastating beneath. Picture the skin staying still while the skeleton shifts downward. And finally, your NCLEX high-yield notes. Pressure is a vertical force that blocks blood flow. Friction is surface rubbing that damages the epidermis, and shear is the downward pull that tears vessels in deeper tissues. Prevention includes repositioning the client every 2 hours, limiting the head of bed to 30 degrees or less, using draw sheets for transfers, and applying supportive devices. Let us move into this next case with a real-life rehabilitation scenario to sharpen your NCLEX preparation. A 78-year-old client is being admitted to a long-term care facility for rehabilitation following coronary artery bypass graft surgery. The client has chronic cardiovascular disease, osteoarthritis, and a stage 2 sacral pressure ulcer. The charge nurse is preparing the interdisciplinary care plan. The key question is, which services should the nurse anticipate will be most beneficial in optimizing this client's recovery? The options include A. Nutritional consult, B. Physical therapy, C. Enterostomal therapy, D. Psychiatric therapy, E. Physician consult, and F. Occupational therapy. The correct answers are A, B, C, E, and F. To begin with, a nutritional consult is absolutely essential. Adequate nutrition is the foundation of wound healing and surgical recovery. A dietitian ensures the client receives protein for tissue repair, calories for overall energy, and vital micronutrients like vitamin C and zinc that stimulate collagen formation and immune defense. Malnutrition in older adults often delays healing and worsens surgical outcomes, making this consult indispensable. Moving on, physical therapy is another critical component. After coronary artery bypass surgery, clients need early and gradual mobilization to restore cardiopulmonary endurance, enhance circulation, and reduce the risk of deep vein thrombosis. Importantly, movement relieves continuous sacral pressure that aggravates ulcers. A physical therapist can also tailor exercises to the client's arthritis, striking a balance between safety and mobility. In addition, an enterostomal therapy nurse plays a specialized role in wound care. Because the client already has a stage 2 sacral ulcer, expert intervention is necessary to prevent infection and progression to stage 3 or 4 ulcers, which carry significant morbidity. An enterostomal therapist provides evidence-based wound care, selects advanced dressings, and teaches prevention strategies such as pressure redistribution and moisture control. Shifting focus, psychiatric therapy is not required at this point. While emotional well-being is important, the scenario does not indicate depression, anxiety, or other psychiatric concerns. General emotional support can be offered by the care team, but specialized psychiatric referral is only needed if assessment reveals mental health issues that may hinder recovery. Next, a physician consult is mandatory. Ongoing follow-up is needed to monitor the client's cardiac function, manage medications such as beta blockers and anticoagulants, and watch for complications like arrhythmias, graft occlusion, or sternal wound infections. Without consistent physician oversight, the client's recovery would be at serious risk. Finally, occupational therapy ensures independence in activities of daily living, such as grooming, dressing, and safe transfers. Arthritis can limit joint mobility and fine motor skills, so occupational therapy helps preserve self-sufficiency, prevents dependence, and enhances quality of life. To summarize the clinical integration, recovery in this complex case requires nutrition for wound healing, physical and occupational therapy for mobility and independence, wound care expertise to manage the pressure ulcer, and physician oversight for medical stability. Psychiatric therapy, while valuable in some cases, is not automatically required here. Stand coast. Pearl. In complex clients, recovery is never about one organ system. It is about integrating nutrition, mobility, wound care, medical oversight, and independence training. Anticipating these services before admission exemplifies true holistic nursing leadership. Let us now move into our next NCLEX practice question, which focuses on client and family education in a community setting. Imagine this scenario. A home health nurse is educating the parents of 3 children after a recent outbreak of pediculosis capitis, commonly known as head lice, in the household. The nurse asks the parents about what they have understood regarding management and prevention. The key question is, which parental statement indicates a need for further teaching? Here are the options. Option A says, lice are gone if I don't see anyone day after treatment. Option B says, I've washed all the bed linens in soap, hot water, and bleach. Option C says, none of my children shares each other's combs or brushes. Option D says, once there is an outbreak, all students should be inspected. The correct answer is option A. Lice are gone if I don't see anyone day after treatment. Now, let us carefully explore the rationale. Pediculosis capitis is a highly contagious condition caused by Pediculus humanus capitis, transmitted through head-to-head contact or indirectly through items like hats, bedding, and combs. Effective management requires knowledge of the life cycle of lice, appropriate treatment, and environmental cleaning. When we consider option A, the parent's belief that lice are gone if they are not visible after one day of treatment reflects a misunderstanding. This is incorrect because lice live for about 30 days, and their eggs, called nits, hatch in 7 to 10 days. Most treatments, such as permethrin 1%, kill live lice, but may not destroy all nits. Therefore, reinfestation can occur if a second treatment is not applied 7 to 10 days later, and if daily nit combing is not performed. Depending on visual inspection alone after 1 day is unsafe, which makes this statement the one requiring further teaching. Moving on to option B, the statement about washing all bed linens in hot water demonstrates correct understanding. Lice and nits cannot survive longer than 48 hours off the scalp, but hot water washing and high heat drying cycles are necessary to break the transmission cycle. Bleach is not essential, but thorough hot water cleaning and drying are sufficient, and non-washable items should be sealed in bags for 2 weeks. Option C, which avoids sharing combs and brushes, is also accurate, because this practice is a major mode of transmission. Combs and brushes should also be soaked in hot water for at least 10 minutes. Finally, option D reflects appropriate knowledge as well, since school-wide inspection of close contacts is part of outbreak control. The American Academy of Pediatrics recommends that children with lice may remain in school, but must begin treatment before returning the next day. Before we finish, let me share some high-yield clinical pearls. The life cycle of lice spans 30 days, and their eggs hatch within 7 to 10 days. First-line treatment must always be repeated within this period to fully eradicate the infestation. Environmental cleaning, including hot water washing and drying, is critical for controlling reinfection. Toxic chemicals such as lindane should be avoided due to serious risks. And finally, the absence of visible lice after a single day does not guarantee that eradication has been achieved. Stand-coast. Pearl. Think of lice as uninvited guests who leave hidden eggs behind. Simply removing the visible adults is not enough. You must wait for the eggs to hatch, treat again, and clean the environment to truly send them packing. Stepping into our next NCLEX practice scenario, we meet a 56-year-old Caucasian male who has been diagnosed with a biopsy-confirmed basal cell carcinoma on his scalp. His health history reveals chronic sun exposure, progressive male pattern baldness, and no significant occupational exposure to radiation or harmful chemicals. The question we must answer is this: which biographical factor most likely contributed to the development of this type of skin cancer? Here are the choices. Option A is chronic cigarette smoking. Option B is male pattern baldness. Option C is employment in a pharmaceutical manufacturing facility. And option D is the use of deodorant soap during daily bathing. The correct answer is option B, male pattern baldness. Basal cell carcinoma is the most common form of skin cancer and is driven largely by prolonged ultraviolet radiation exposure. Unlike melanoma or squamous cell carcinoma, basal cell carcinoma grows slowly and rarely metastasizes, but it can cause severe local destruction if untreated. Areas of the body most at risk include the scalp, face, ears, nose, and hands, regions commonly exposed to sunlight. Male pattern baldness removes the hair's natural protection, leaving the scalp vulnerable to direct ultraviolet damage. In fair-skinned individuals, this leads to DNA mutations in basal keratinocytes, particularly affecting tumor suppressor genes such as P53, which significantly increases the risk of basal cell carcinoma. Looking at the other options, option A, chronic cigarette smoking, is strongly associated with cancers of the lungs, bladder, pancreas, and oral cavity, but has little correlation with basal cell carcinoma. Option C, employment in a pharmaceutical manufacturing facility, would only be significant if the client had direct exposure to carcinogens like arsenic or ionizing radiation, which was not indicated here. Option D, the use of deodorant soap, is unrelated to cancer formation. While soap can irritate the skin, it does not cause malignant transformation. From a nursing care standpoint, prevention is a major priority. Primary prevention focuses on protecting clients through sunscreen, hats, and sun avoidance during peak hours. Secondary prevention emphasizes routine skin checks and annual dermatology assessments for early detection. Tertiary care includes treatments such as surgical excision, Mohs, micrographic surgery, cryotherapy, and topical immunotherapy, with nurses reinforcing adherence to follow-up care since recurrence is common. And here is your stand-coast pearl. Hair is nature's umbrella. When it is lost, the scalp becomes a direct target for ultraviolet radiation, making baldness a silent yet powerful risk factor for skin cancer in fair-skinned individuals. Star, I want to tell you something. If you're aiming to pass on your very next attempt, the ultimate NCLEX Crash Course is your shortcut, already trusted by more than 100,000 nursing students Who cleared their exams successfully? What makes it different? It's an all-in-one package, designed to cover every part of your NCLEX prep. Interactive live classes and easy to watch. Recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail, during comprehensive lecture. This isn't just another review, it's everything you need in one. Please scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes you'll also get. Let us begin with an engaging NCLEX-style practice question that highlights a critical pharmacology teaching point. A 22-year-old female client is prescribed isotretinoin, also known as Accutane, for severe cystic acne that has not responded to conventional therapy. The nurse must determine which area of health teaching is most essential to prevent the most serious complication. Here are the options to consider. Option A is instruction on proper breast self-examination techniques. Option B is education regarding strict pregnancy prevention measures. Option C is counseling about methods for predicting ovulation cycles. And option D is guidance on preventing sexual transmission of acne. The correct answer is option B, education regarding strict pregnancy prevention measures. Now, let us explore the reasoning behind this choice. Isotretinoin is a vitamin A derivative reserved for severe resistant acne vulgaris, but its greatest danger is its profound teratogenic effect. Classified as an FDA Pregnancy Category X medication, isotretinoin poses an absolute fetal risk, with no situation where its use in pregnancy is justified. Even a single exposure during pregnancy can result in miscarriage or devastating congenital anomalies, including craniofacial malformations such as cleft palate and ear deformities, central nervous system abnormalities like hydrocephalus and microcephaly, cardiovascular defects, and parathyroid or thymic abnormalities. To ensure safety, isotretinoin is dispensed under the strict I-Pledge program in the United States, which mandates 2 negative pregnancy tests before initiation, ongoing monthly pregnancy testing, proof of 2 reliable contraceptive methods used simultaneously, and counseling that pregnancy must be avoided during therapy and for at least 1 month after discontinuation. This makes pregnancy prevention counseling the highest priority teaching for clients. Shifting focus to the incorrect responses, option A, instruction on breast self-examination techniques, is a valuable health promotion measure but is unrelated to isotretinoin, which does not increase the risk of breast cancer. Option C, methods for predicting ovulation cycles, is unsafe because fertility awareness methods carry a much higher failure rate than hormonal or barrier methods, and even one accidental exposure during pregnancy can result in catastrophic birth defects. Option D, guidance on preventing sexual transmission, is irrelevant since acne vulgaris is not an infectious disease and cannot be transmitted through sexual activity. From a broader nursing perspective, additional teaching must include awareness of other adverse effects, such as dryness of skin and mucous membranes, cheilitis, nosebleeds, photosensitivity, hyperlipidemia, hepatotoxicity, and potential psychiatric effects including depression and suicidal ideation. Clients require periodic laboratory monitoring, specifically liver function tests and lipid panels. Nurses must also caution clients to avoid vitamin A supplements due to toxicity risk, and to refrain from blood donation during treatment and for 1 month afterward to prevent harm to pregnant transfusion recipients. Here is the NCLEX strategy pearl to carry forward. When answering pharmacology questions, always ask which complication poses the greatest threat to life or safety. With isotretinoin, the teratogenic risk is paramount, and therefore the teaching that must be prioritized is strict pregnancy prevention. This aligns perfectly with the NCLEX testing principle of selecting the intervention that directly prevents the most dangerous complication rather than one that simply promotes general health. Let us dive into the first question of this script with a real-world scenario that many athletes encounter. A community health nurse is educating a group of athletes who struggle with frequent recurrences of tinea pedis, commonly known as athlete's foot. The key question is, which preventive measure is the most important to reduce fungal proliferation and prevent recurrent infection? Here are the options to consider. Option A suggests never going barefoot when outdoors. Option B advises cutting the toenails straight across. Option C recommends wearing a different pair of shoes each day. And option D suggests avoiding the use of white cotton socks. The correct answer is option C, wearing a different pair of shoes each day. This recommendation is the most effective because it directly targets the environment in which the fungus thrives. Dermatophytes such as Trichophyton rubrum and Trichophyton interdigital flourish in dark, moist, and warm environments, which are exactly the conditions created inside sweaty shoes. By alternating footwear, moisture has time to evaporate, humidity decreases, and fungal spores have less chance of surviving. This simple intervention disrupts the fungal life cycle and is strongly supported by evidence-based guidelines for preventing recurrences, especially in athletes, soldiers, and individuals prone to excessive sweating. Looking at why the other options are not as effective, let us start with option A, never going barefoot outdoors. While communal wet areas like locker rooms, showers, and swimming pools can increase the risk of reinfection, being barefoot outdoors in dry, ventilated spaces does not typically promote fungal growth. In fact, open-air exposure can help keep feet dry. Therefore, this advice is too general and not the most effective prevention strategy. Moving to option B, cutting the toenails straight across. Although this practice is excellent for preventing ingrown toenails, it does not significantly impact the prevention of athlete's foot. The infection affects primarily the skin of the feet, particularly between the toes, rather than the nails themselves. Finally, option D, avoiding white cotton socks, is actually counterproductive. Cotton socks are beneficial because they absorb moisture and help wick sweat away from the skin. The real concern is synthetic fabrics that trap heat and sweat, not cotton. Therefore, avoiding white cotton socks would actually reduce one of the best protective measures. To strengthen your NCLEX preparation, here are some clinical pearls. Always remember that fungi thrive in dark, moist, warm conditions, and shoes with trapped sweat provide the perfect incubator. The best prevention strategies include alternating shoes, using antifungal powders or sprays, wearing breathable cotton socks, and ensuring good foot hygiene. Nurses should teach clients to wash and dry their feet thoroughly, especially between the toes, avoid sharing towels or shoes, and use sandals in high-risk communal areas. If Tinea pedis is left untreated, it can lead to more serious complications such as fungal nail infections, bacterial superinfections, and even cellulitis in vulnerable populations, like those with diabetes or immunocompromise. Stand coast. Pearl. Tinea pedis lives where sweat stays. Dry the feet, change the shoes, and let the air in. This simple step stops the fungus before it starts again. To kick things off with a thought-provoking case, imagine a 64-year-old client admitted with a painful unilateral vesicular rash that follows a dermatomal distribution. The nurse quickly identifies this as herpes zoster or shingles. The client recalls having chickenpox in childhood and is curious about why shingles can suddenly occur later in life. Here are the possible explanations. Option 1 states that it is due to the reactivation of a dormant varicella zoster virus within the sensory nerve ganglia. Option 2 suggests transmission from a vector such as a tick, carrying viral particles. Option 3 proposes toxin production from a bacterial infection that damages the skin and nerves. And option 4 argues it results from an antibody hypersensitivity reaction triggered by a drug allergen. The correct answer is option 1, the reactivation of a dormant varicella zoster virus within sensory nerve ganglia. Shingles develops when the varicella zoster virus, the same virus that causes chickenpox, reawakens after lying dormant in the dorsal root ganglia for years or even decades. When the immune system becomes weakened by age, stress, immunosuppression, malignancy, or corticosteroid therapy, the virus begins replicating along the affected sensory nerve. This causes burning pain, tingling, and the hallmark vesicular rash limited to a dermatome. Severe complications include postherpetic neuralgia, ophthalmic involvement that can threaten vision, and widespread infection in immunocompromised individuals. Prevention is crucial, which is why the recombinant zoster vaccine, Shingrix, is recommended for adults 50 years and older, regardless of past chickenpox or shingles history. In contrast, option 2 is incorrect because shingles is not spread by vectors like ticks. Vector-borne illnesses include Lyme disease, Rocky Mountain spotted fever, and babesiosis, none of which resemble shingles' dermatomal rash. Option 3 is also incorrect since bacterial toxins are not involved. Shingles results from viral reactivation, not bacterial exotoxins. Misdiagnosis could lead to unnecessary antibiotic use, which offers no benefit. Finally, option 4 is incorrect because drug allergies typically cause diffuse rashes, hives, or systemic hypersensitivity reactions, but not a unilateral dermatomal rash. For NCLEX recall, keep this memory trick in mind. Chickenpox sleeps in the ganglia, shingles wakes it up. Key signs are the painful rash on one side of the body that never crosses the midline. Nursing interventions include early initiation of antiviral therapy within 72 hours, implementing airborne and contact precautions until lesions crust over, and monitoring older adults and immunocompromised clients who are at highest risk for complications. Stand coast. Pearl, herpes zoster is not a new invader. It is your childhood chickenpox reawakened. Dormant in the dorsal root ganglia for years, it waits for immunity to weaken, then resurfaces as shingles. Let us now move forward with another NCLEX practice scenario that focuses on herpes zoster, also known as shingles. The nurse is teaching the family of a client diagnosed with this condition about the expected progression of clinical manifestations, and the task is to arrange the symptoms in the correct chronological order. Here are the options to consider. Pain develops and severe itching follows, low-grade fever and malaise. The dermatome area develops a red blotchy appearance, unilateral vesicles appear, and scarring or permanent skin discoloration is noted. The correct order to remember is 2, 3, 4, 1, 5. To begin with, the earliest stage of shingles is the prodromal phase where nonspecific systemic symptoms such as low-grade fever, headache, malaise, and fatigue appear. This is option 2. These vague symptoms are triggered by the dormant varicella zoster virus reactivating within the dorsal root ganglia, leading to inflammation before the rash manifests. This stage usually lasts 1 to 5 days and may initially be mistaken for a simple viral illness. Transitioning to the next phase, the affected dermatome develops a red blotchy appearance, which is option 3. This rash uniquely follows a dermatomal and unilateral distribution, which is a hallmark sign of shingles. At this point, the skin in that area becomes hypersensitive and tender. Moving further into the disease progression, within 24 to 48 hours, clusters of vesicles appear on the reddened dermatome, corresponding to option 4. These vesicles are fluid-filled, unilateral, and very painful, typically occurring on the trunk, thoracic region, or sometimes the face. Special attention is required when the ophthalmic branch of the trigeminal nerve is involved, as this can pose a threat to vision. As the vesicles form and the nerves become inflamed, the client begins to experience severe neuropathic pain and itching, which corresponds to option 1. This burning, stabbing, or shooting pain is often the most distressing symptom and may persist long after the rash resolves, a complication known as postherpetic neuralgia. Finally, as healing occurs, scarring or permanent skin discoloration may remain, which is option 5. While many clients recover in 2 to 4 weeks, older adults are more prone to lingering complications such as altered pigmentation, chronic neuralgia, or even secondary infections. From an NCLEX perspective, here are some high-yield pearls to lock in. Early clues such as pain or burning in a specific dermatome before the rash appears are classic prodromal indicators of shingles. The lesion characteristics are also diagnostic. Shingles vesicles are unilateral, clustered, and dermatomal, which sets them apart from chickenpox, where lesions are diffuse and bilateral. Common complications include postherpetic neuralgia, vision loss in cases of ophthalmic involvement, and disseminated infection in immunocompromised individuals. Finally, do not forget prevention. The Shingrix vaccine is strongly recommended for adults 50 years and older, even if they have previously had shingles. Let us now move into our next practice question, which focuses on client teaching for herpes simplex virus type 1. Imagine a client who has just been diagnosed with HSV1 and is preparing for discharge. The nurse must decide which instruction is the most critical to emphasize in order to prevent serious complications. Here are the options to consider. Option A suggests applying petroleum jelly to the lesions several times daily to promote healing and prevent viral spread. Option B recommends maintaining meticulous hand hygiene and avoiding touching the lesions to prevent auto-inoculation to other sites, especially the eyes and genital area. Option C advises avoiding cleansing the lesions with soap and water, as this may irritate the tissue and delay healing. Option D proposes removing crusts and scabs daily using hot compresses, to promote drainage and healing. The correct answer here is option B, maintain meticulous hand hygiene and avoid touching the lesions to prevent auto-inoculation to other sites, especially the eyes and genital area. This is the most important teaching point because HSV-1 is highly contagious and spreads through direct contact with infected secretions. Clients can accidentally spread the virus to their eyes, leading to herpetic keratitis, which is a vision-threatening emergency, or to their genital area, causing a new site of infection. Teaching clients about proper hygiene, avoiding direct contact, and using disposable applicators or gauze for cleansing plays a vital role in preventing these complications. When we examine option A, although petroleum jelly can help reduce dryness and cracking, it does not stop viral spread and may even delay the healing process by keeping the lesions overly moist. That means it offers comfort but not real protection against transmission. Moving to option C, avoiding soap and water is unsafe advice. In fact, gentle cleansing with mild soap and water helps remove debris and reduces the risk of bacterial superinfection. Finally, looking at option D, removing scabs manually is harmful and delays recovery. Scabs should always be allowed to fall off naturally, because forcibly removing them increases the risk of infection and prolongs viral shedding. Clinically, it is essential to understand that HSV-1 is a lifelong infection that lies dormant in the sensory ganglia and can be reactivated by stress, fever, sunlight, or immunosuppression. The most serious complication is ocular involvement, but immunocompromised clients are also at risk of systemic dissemination. Treatment with antiviral agents such as acyclovir or valacyclovir can help shorten outbreaks, but will not cure the infection. During counseling, nurses should stress avoiding kissing, sharing utensils, and engaging in oral genital contact during active outbreaks, as lesions remain contagious until they are fully healed. And here is your Stancoast pearl to tie this together. Cold sores may look harmless, but the real danger is where the virus travels. A single touch from lip to eye can mean permanent vision loss. Hand hygiene is the nurse's strongest weapon against HSV spread. Shifting our focus to a classic dermatology scenario, let us explore a client who has been living with plaque psoriasis for many years and is now being assessed at a dermatology clinic. During the nurse's careful examination of common sites such as the scalp, elbows, and knees, the question arises, which clinical finding should the nurse expect as the most characteristic of this disorder? The possible answers include option A, moist and weeping lesions scattered along the trunk, option B, sharply demarcated erythematous plaques covered with silvery white scales, option C, tense fluid-filled blisters surrounded by yellow-brown crusts, and option D, a diffuse erythematous rash with scattered pustules across the extremities. The correct answer is option B, sharply demarcated erythematous plaques covered with silvery white scales. Psoriasis vulgaris, also known as plaque psoriasis, is an immune-mediated chronic skin disorder where keratinocyte hyperproliferation and T-cell dysregulation cause accelerated skin turnover, 2 to 3 days instead of the normal 28. This produces thick, dry plaques with silvery white scales that can be scraped off, often leaving pinpoint bleeding underneath, a finding known as the Auspitz sign. These plaques most often appear symmetrically on extensor surfaces, the scalp, and sacral regions. Stress, infections, cold environments, and medications such as lithium and beta blockers are common triggers for flare-ups. Looking at the distractors, option A does not fit because moist and weeping lesions are more typical of eczema or atopic dermatitis, which is pruritic, oozing, and often associated with allergies or asthma. Option C points to blistering with crusts, which is more consistent with impetigo or bullous pemphigoid, conditions that are infectious or autoimmune, not psoriasis. Option D, a widespread rash with pustules, reflects generalized pustular psoriasis or severe drug eruptions such as acute generalized xanthematis pustulosis, but this is far less common than the classic plaque form highlighted in NCLEX questions. From a nursing perspective, it is important to assess for thick, scaly plaques with symmetrical distribution, but also to recognize complications such as psoriatic arthritis, which affects up to 30% of clients and leads to painful, stiff joints. The psychosocial burden should not be overlooked, as psoriasis is non-contagious but often stigmatized, leading to depression, anxiety, and poor self-image. Treatment strategies range from topical corticosteroids, vitamin D analogs, coal tar, and emollients for mild cases, to narrowband UVB phototherapy for widespread disease, to systemic agents such as methotrexate, cyclosporine, or biologics like TNF-alpha and IL-17 inhibitors for severe or resistant cases. Nurses must also teach clients to avoid known triggers, keep their skin well hydrated, and use fragrance-free products. Stand Coast, Pearl. When you think of psoriasis, always think plaques and scales, dry, chronic, and sharply outlined. If you encounter oozing, blisters, or crusts, shift your suspicion toward eczema, infection, or bullous conditions instead. Shifting into our next clinical challenge, imagine a client with visible erythematous plaques on the lower arms who feels embarrassed about their appearance and turns to the nurse asking, "What exactly is causing this skin condition?" The nurse must identify the underlying pathophysiologic process that best explains psoriasis. Here are the possible answers. Option 1, a superficial skin infection caused by bacterial or fungal overgrowth. Option 2, damage to the dermis and epidermis from repeated skin abrasion. Option 3, a chronic immune-mediated hyperproliferation of epidermal keratinocytes. And Option 4, an acute infection localized within the sebaceous glands and hair follicles. The correct answer is Option 3, a chronic immune-mediated hyperproliferation of epidermal keratinocytes. Now, let us carefully reason this out. Psoriasis is not just a surface problem. It is a systemic, immune-driven condition. T lymphocytes become overactive, releasing pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin-17, and interleukin-23. This immune cascade accelerates keratinocyte turnover from the normal 28-day cycle to only 3 to 4 days. The result is an accumulation of immature keratinocytes, producing the classic sharply demarcated erythematous plaques covered with silvery scales on areas like the scalp, elbows, knees, and lower back. Because it is non-infectious and chronic, treatment often extends beyond creams to include biologic therapies targeting specific immune pathways. It is also linked with systemic comorbidities such as psoriatic arthritis, metabolic syndrome, and cardiovascular disease, reminding nurses that psoriasis goes far beyond the skin. On the other hand, considering Option 1, a superficial skin infection, this is inaccurate. Psoriasis cannot spread from person to person. It is not contagious, bacterial, or fungal. In fact, clients often experience stigma because others mistakenly fear infection, making nurse education vital. Moving to Option 2, the idea of repeated abrasion, this too is incorrect. While trauma can trigger lesions at sites of injury through the Koebner phenomenon, skin abrasion alone does not explain the autoimmune mechanism at work. Finally, Option 4, infection of the hair follicles, is actually describing folliculitis, where Staphylococcus aureus causes localized pustular lesions around hair follicles. That is very different from the broad plaques of psoriasis. Here is the high-yield clinical takeaway for your NCLEX preparation. Psoriasis is a T-cell-mediated autoimmune condition that creates rapid epidermal turnover and silvery white plaques. It is non-infectious, often misunderstood, and associated with both skin and systemic complications. Remember its common triggers, such as stress, trauma, and medications like beta blockers or lithium. Management spans from topical steroids and vitamin D analogs to systemic immunosuppressants and biologics. Stand Coast, Pearl. Think of psoriasis as skin cells on fast forward, producing 6 to 9 times faster than normal, creating thick, scaly plaques that are not contagious but are immune-driven. Shifting into another important clinical scenario, consider a nursing assistant employed in a hospital who has a documented allergy to latex and is assigned to care for multiple clients, including those with blood-borne infections such as HIV and hepatitis C. The nurse must provide the safest advice for protecting both the worker and the clients while maintaining compliance with standard precautions. Here are the options. First, rinse your latex gloves with running tap water before putting them on. Second, apply a petroleum-based ointment to your hands before putting on latex gloves. Third, avoid wearing gloves, but wash your hands vigorously with alcohol after client contact. And fourth, use non-latex alternatives such as vinyl or nitrile gloves. And if using vinyl gloves, wear 2 pairs when anticipating contact with body fluids. The correct answer is Option 4, which states to use non-latex alternatives, such as vinyl or nitrile gloves, with double layering if vinyl gloves are chosen. Now, let us carefully reason this out. The safest and most evidence-based approach is to eliminate latex exposure entirely, because latex allergy can cause reactions ranging from mild to severe contact dermatitis to life-threatening anaphylaxis. Nitrile gloves are considered the gold standard latex alternative because they are more durable, puncture-resistant, and provide a strong barrier against blood-borne pathogens. Vinyl gloves, on the other hand, are more permeable, but wearing 2 pairs significantly improves barrier protection and maintains safety. This approach not only protects the nursing assistant from allergen exposure, but also ensures client safety by adhering to OSHA and CDC standards for personal protective equipment and infection control. Looking at the incorrect choices, rinsing latex gloves with water does not eliminate latex proteins, and in fact, added moisture can damage the glove and increase permeability. Similarly, applying petroleum-based ointment under latex gloves is unsafe because petroleum degrades latex material, creating microtears that increase the risk of infection transmission and still does not prevent an allergic reaction. Finally, avoiding gloves and depending only on alcohol, hand hygiene after contact is a direct violation of standard precautions, as gloves are a required barrier method whenever blood or body fluids may be encountered. From an exam perspective, it is also important to recall that latex allergy reactions can be classified as type 1 IgE-mediated hypersensitivity, leading to urticaria, bronchospasm, or even anaphylaxis, or as type 4 delayed hypersensitivity with localized dermatitis. For clients and staff with latex sensitivity, all medical equipment, including catheters, syringes, and stethoscopes, should be latex-free to prevent exposure. Here is the high-yield Stand-Coast Pearl. Latex allergy is not managed by reducing exposure, it is prevented only by complete avoidance. Latex-free gloves protect the healthcare worker while ensuring infection control, creating safety for both provider and client. Let us move forward in our NCLEX-style journey with another important scenario that tests your knowledge about latex allergy reactions. A nursing assistant with a documented history of sensitivity to natural rubber proteins mistakenly donned latex gloves while preparing to assist with client care. Minutes later, the nurse notices concerning changes. The question asks, which assessment findings most strongly indicate that the nursing assistant is experiencing a latex-induced allergic reaction? Remember, this is a select all that apply question, so think carefully about all possible signs. Here are the options. Option 1 is raised areas and blisters on the hands. Option 2 is itchy, red, watery eyes. Option 3 is a runny nose. Option 4 is nausea and vomiting. Option 5 is generalized hives. Option 6 is chest tightness. The correct answers are options 1, 2, 3, 5, and 6. Now let us carefully walk through the reasoning. Beginning with option 1, raised areas and blisters on the hands represent a localized type 4 delayed hypersensitivity reaction, also called allergic contact dermatitis. This is mediated by T lymphocytes and typically develops after exposure to latex. You may see erythema, papules, vesicles, and blistering at the point of contact. Although not as rapidly life-threatening as anaphylaxis, this still indicates clear latex sensitivity. Moving to option 2, itchy, red, watery eyes are a classic sign of mucous membrane involvement due to airborne latex proteins, especially from powdered gloves. This reflects a type 1 immediate IgE-mediated hypersensitivity reaction. Histamine release causes tearing, conjunctivitis, and irritation. Recognizing these early systemic signs is crucial because they can rapidly progress to more severe reactions. Next, option 3, a runny nose, is another hallmark feature of type 1 hypersensitivity. Inhaling aerosolized latex proteins leads to sneezing, rhinorrhea, nasal congestion, and postnasal drip. In healthcare workers who are frequently exposed, this sensitivity often worsens over time and can escalate to systemic reactions. Continuing to option 5, generalized hives, or urticaria, is a systemic IgE-mediated immune response. Widespread histamine release produces raised, itchy welts across the skin. This confirms immune system activation beyond localized contact and signals a risk for progression to life-threatening anaphylaxis. Option 6, chest tightness, is especially concerning. This reflects respiratory involvement such as bronchospasm or laryngeal edema. Symptoms like wheezing, stridor, and difficulty breathing are red flag signs of impending anaphylaxis. Immediate removal of latex, administration of epinephrine, and airway support are mandatory at this stage. Finally, let us address option 4, nausea and vomiting, which is incorrect in this scenario. While gastrointestinal symptoms are possible in food allergies, such as with bananas, kiwis, or avocados, that cross-react with latex, nausea and vomiting are not typical of direct latex glove exposure. They are nonspecific and therefore less reliable as diagnostic indicators. To put this into context, healthcare workers are at higher risk of latex allergies due to repeated exposure. There are two major mechanisms. Type 1, IgE-mediated immediate hypersensitivity that can progress to anaphylaxis, and Type 4 delayed hypersensitivity presenting as contact dermatitis. Nurses must act quickly, remove all latex products, notify the provider, apply emergency protocols when systemic symptoms appear, and ensure latex-free alternatives like nitrile or vinyl gloves are used in the future. Documentation and wearing a medical alert bracelet are also important safety measures. From a test-taking perspective, when you see Select All That Apply allergy questions, focus on immune-mediated symptoms involving the skin, eyes, nose, and especially the respiratory system. Eliminate nonspecific gastrointestinal complaints unless food ingestion is involved. Always prioritize airway and breathing, so any option involving chest tightness or respiratory distress deserves your immediate attention. Stancoast, Pearl. Latex allergy can escalate from mild irritation to full-blown anaphylaxis within minutes. The earliest clues, itchy eyes, runny nose, or hives, should never be ignored. And remember, chest tightness is a life-threatening sign that calls for immediate epinephrine. Let us now walk into a scenario that many nurses may face in cold environments. Managing frostbite. A client who has experienced prolonged exposure to freezing temperatures presents to the clinic seeking first aid guidance for suspected frostbite of the fingers. The question asks, which immediate intervention should the nurse recommend to promote optimal tissue recovery? Here are the options to consider. The first option is to soak the affected fingers in a warm water bath maintained between 100 and 106 degrees Fahrenheit, which equals 37.7 to 41.1 degrees Celsius. The second option suggests beginning the rewarming process by applying cold, moist compresses directly to the affected areas. The third option recommends placing an electric heating pad on the highest setting over the affected fingers for rapid warming. The fourth option advises immersing the affected fingers in hot water, maintained at approximately 140 degrees Fahrenheit, or 60 degrees Celsius. The correct answer is option 1, which is to soak the affected fingers in a warm water bath maintained between 100 and 106 degrees Fahrenheit, or 37.7 to 41.1 degrees Celsius. This method is considered the gold standard because controlled immersion in warm, not hot, water allows gradual vasodilation, restoration of microcirculation, and oxygen delivery to ischemic tissues. Importantly, rewarming within this range prevents refreezing, minimizes necrosis, and reduces reperfusion injury when oxygenated blood returns to ischemic areas. Clients often describe this process as very painful due to nerve fiber reactivation, so pain management is also essential. Controlled rewarming has been shown to improve tissue survival and reduce the need for amputation. On the other hand, the second option, using cold compresses, is incorrect because cold application only worsens vasoconstriction and delays rewarming. Frostbite already results from ice crystal formation and prolonged vasoconstriction, so this method would deepen the injury. Moving to option 3, applying a heating pad at the highest setting is unsafe because frostbitten tissue loses sensation and clients cannot accurately detect excessive heat. This puts them at high risk of burns and uneven rewarming, which worsens necrosis. Finally, option 4, immersing tissue in hot water at 140 degrees Fahrenheit, is dangerous because fragile frostbitten tissue cannot tolerate such extremes. Instead of healing, it causes burns, accelerates tissue death, and increases infection risk. To bring this together with NCLEX high-yield learning, remember that priority frostbite care involves preventing further cold exposure, starting gentle rewarming at 100 to 106 degrees Fahrenheit, and providing analgesics to manage the severe pain of rewarming. Nurses must never massage frostbitten areas because rubbing causes mechanical trauma and ruptures intracellular ice crystals. Systemic hydration and oxygenation also support tissue recovery, while advanced hospital care may involve vasodilators or thrombolytics in severe cases. Here is the Stand Coast Pearl for this topic. Frostbite care is all about gentle rescue, not aggressive rescue. Rewarm slowly, avoid extremes, manage pain, and protect fragile tissue from further harm. Let us now move into our next NCLEX-style scenario with a focus on dermatologic nursing care. A 52-year-old client comes to the outpatient dermatology clinic reporting persistent pruritus related to xerosis, also known as dry skin. The nurse understands that this discomfort is not only irritating but also a result of impaired skin barrier function, excessive transepidermal water loss, and heightened nerve sensitivity. The question asks, which nursing instruction would best promote comfort, maintain skin integrity, and reduce itching in this client? Here are the options to consider. The first option is to use hypoallergenic or glycerin-based soap during bathing. The second option is to apply moisturizing lotion to the affected skin every other day. The third option is to take warm showers rather than tub baths. The fourth option is to rub the skin dry with a towel immediately after bathing. The correct answer is option 1, advising the client to use hypoallergenic or glycerin-based soap during bathing. This choice is the most evidence-based because harsh alkaline soaps strip the natural lipid barrier, increasing dryness and itching. In contrast, hypoallergenic and glycerin-based soaps are milder and function as humectants, drawing and retaining moisture within the outer skin layers. Dermatology guidelines emphasize pairing these cleansers with immediate moisturization as the cornerstone of xerosis care. Now, let us examine why the other options are not correct. Option 2, applying moisturizing lotion every other day, is inadequate because moisturization must be done daily, and especially right after bathing. Skipping days allows water loss and worsens itching. Evidence-based practice recommends the soak and seal method, where skin is moisturized within 3 minutes after bathing to trap hydration. Moving to option 3, taking warm showers rather than tub baths, this instruction is misleading. Short tepid showers are acceptable, but tub baths are not harmful as long as the water is lukewarm and the time is limited. In fact, soaking followed by immediate moisturization can improve hydration. The real danger lies in hot water exposure, not in the type of bathing. Finally, option 4, rubbing the skin dry with a towel, is clearly harmful because friction causes irritation, disrupts the protective skin layer, and may cause micro tears. Best practice is to gently pat the skin dry, leaving slight moisture behind, and then seal it in with an emollient. From a clinical nursing perspective, managing dry skin is about more than just comfort. It prevents serious complications such as fissures, excoriations, and secondary infections. Nurses must also teach lifestyle modifications like using humidifiers in dry weather, wearing soft cotton fabrics, avoiding irritants such as perfumes or alcohol-based products, and ensuring adequate hydration. Here is your Stand Coast Pearl. Skincare in xerosis follows the 3P rule. Pick mild soap, pat skin dry, and protect with moisturizer immediately. Anything that strips, delays, or rubs will worsen dryness, itching, and skin breakdown. Let us now dive into another important NCLEX-style scenario that tests your understanding of wound classification and healing. A nurse working in a specialized wound care clinic is developing individualized care plans for clients with different types of wounds. The question asks, which wound should the nurse correctly classify as a chronic wound, requiring a prolonged and multifaceted approach to healing and management? Here are the options to consider. The first option is a gunshot wound with tissue damage. The second option is a slow-healing diabetic foot ulcer. The third option is a stage 1 pressure injury on the coccyx. And the fourth option is a 7-day-old infected surgical wound. The correct answer here is option 2, a slow-healing diabetic foot ulcer. This wound is the hallmark example of a chronic wound. Chronic wounds are those that fail to progress through the normal orderly stages of healing within the expected time frame, which is usually more than 3 months. And they often remain stuck in the inflammatory phase. In diabetes, multiple factors such as peripheral neuropathy, vascular insufficiency, impaired immune response, and microvascular changes interfere with perfusion and oxygen delivery to tissues. Because of these barriers, diabetic foot ulcers frequently recur, remain resistant to conventional treatment, and may require advanced therapies such as offloading, frequent debridement, negative pressure wound therapy, or even hyperbaric oxygen therapy. These wounds are a leading cause of lower extremity amputations worldwide, which makes their recognition and management absolutely critical for nurses. Moving on to option 1, the gunshot wound with tissue damage is incorrect, because although traumatic wounds may be extensive and complicated, they are classified as acute wounds. Acute wounds follow the predictable phases of healing: hemostasis, inflammation, proliferation, and maturation, so long as infection and perfusion are controlled. Any delay in healing here is considered a complication, not a chronic state. Shifting our attention to option 3, a stage 1 pressure injury on the coccyx. This too is incorrect, because at this early stage, the skin is intact but shows non-blanchable redness. It is not yet considered chronic, as with proper pressure redistribution, moisture management, and nutrition, it can often heal quickly and fully. Chronic classification is more appropriate for deeper, non-healing pressure injuries at stage 3 or 4. Lastly, let us evaluate option 4, a 7-day-old infected surgical wound, which is also incorrect. Surgical wounds normally heal by primary intention if they remain free of infection and receive adequate perfusion. While infection may temporarily delay healing, appropriate antibiotics, drainage, and wound care typically restore the wound back to an acute healing trajectory, not a chronic one. Here are some clinical pearls to keep in mind for the NCLEX. Chronic wounds are defined by failure to heal within 3 months or more, and they often remain stuck in the inflammatory phase. The most common examples include diabetic foot ulcers, venous stasis ulcers, and advanced pressure injuries at stage 3 or 4. The underlying pathophysiology usually involves impaired perfusion, reduced oxygenation, neuropathy, repeated trauma, and infection, all of which perpetuate poor healing. The nursing role includes comprehensive wound assessment, risk factor modification such as blood sugar control, smoking cessation, and pressure offloading, as well as the use of advanced wound dressings and interprofessional collaboration. From a test-taking standpoint, always look for key phrases like slow healing, non-healing, long-standing, or fails to progress to identify chronic wounds. And here is your Stancoast Pearl to lock this in. Chronic wounds are not just slow wounds. They are pathologically stuck in the healing cycle. Think diabetes, venous disease, and advanced pressure injuries whenever you see the word chronic. All right, let us smoothly step into this NCLEX-style scenario together. A client presents to the clinic with a generalized rash involving the trunk and extremities, and the nurse must carefully assess potential triggers. The question asks which assessment questions should be prioritized to identify the cause. Here are the options to think about. The first option is, have you eaten any foods that are different from your usual diet? The second option is, have you taken any new medications, prescription, or over-the-counter? The third option is, have you recently changed your laundry detergent, soap, or body lotion? The fourth option is, have you been exposed to excessive sunlight or used tanning equipment? The fifth option is, have you been exercising in a gym more frequently than usual? And the sixth option is, have you gotten any new pets or had contact with animals not previously around you? The correct answers are options 1, 2, 3, and 6, because these are the most relevant assessment points that focus on potential allergens or irritants. Now, let us carefully break down the reasoning behind these choices. Beginning with option 1, asking about dietary changes is essential, since food hypersensitivities are among the most common causes of allergic rashes, including urticaria and angioedema. Foods like shellfish, nuts, dairy, eggs, and strawberries can trigger IgE-mediated histamine release, leading to immediate or delayed skin eruptions. Identifying dietary triggers allows nurses to initiate avoidance strategies and reduce recurrence. Moving into option 2, assessing for new medications is equally critical because drug eruptions are one of the leading causes of outpatient rashes. Common culprits include antibiotics like penicillins and sulfonamides, anticonvulsants, NSAIDs, and even herbal supplements. These can produce anything from mild maculopapular rashes to severe life-threatening conditions such as Stevens-Johnson syndrome. This makes medication history a non-negotiable part of safe nursing assessment. Transitioning into option 3, asking about new laundry detergents, soaps, or lotions helps identify contact dermatitis. Irritant or allergic dermatitis often begins locally with erythema, itching, and swelling, but can easily spread if allergens are present in clothes, bedding, or shared environments. This line of questioning gives the nurse clues about external exposures that are modifiable. Shifting focus now to option 6, new pets or animal contact are another significant cause of rashes. Dander, saliva, and mites from cats, dogs, or other animals can cause allergic reactions, including atopic dermatitis or hives. If the timing of the rash coincides with the introduction of a pet, it strongly points toward an environmental allergen as the trigger. Now, let us consider why the remaining options are not correct. Looking at option 4, while sun exposure may cause erythema or burns, it is not typically a root cause of a generalized allergic rash unless linked to photosensitive medications. Therefore, asking about sunlight broadly is less clinically useful in this context. Shifting to option 5, frequent exercise may lead to heat rash or aggravate fungal infections due to sweating, but it is not a primary factor to investigate when identifying systemic or allergic causes of rashes. On the NCLEX, lifestyle activities are generally deprioritized compared to allergens, medications, and environmental exposures. In terms of clinical nursing integration, the key principle here is the nursing process. The first step, assessment, requires gathering comprehensive data about possible allergens, medications, and exposures before diagnosis and planning. From a patient safety perspective, quickly identifying whether the rash has an allergic origin is essential because missing a food, drug, or environmental trigger could allow progression to more severe conditions, including systemic anaphylaxis. Finally, education is equally important. Nurses must teach clients how to avoid identified triggers, recognize early signs of recurrence, and seek immediate care for any systemic symptoms like difficulty breathing or swelling. From an NCLEX test-taking strategy standpoint, remember that in Select All That Apply questions, you should focus on allergens and irritants first. Eliminate distractors that are non-specific lifestyle factors unless directly tied to the condition. Always align your priority with safety and assessment. And here is your Stan Coast Pearl to lock it in. When investigating a rash, always think allergens first. What the client eats, swallows, touches, or breathes. Sunlight and exercise may irritate, but allergens reveal the root cause. Let us smoothly transition into this next NCLEX-style scenario that highlights cancer prevention and risk awareness. The nurse is counseling a group of clients about malignant melanoma, which is the deadliest form of skin cancer despite being less common than basal cell or squamous cell carcinoma. The question asks, which client profile should the nurse identify as having the highest risk for developing malignant melanoma? The first option is an African American client with dark skin and dark hair. The second option is a Scandinavian client with freckles and blue eyes. The third option is a Mexican client with tan skin and dark brown hair. The fourth option is a Caucasian client with brown hair and brown eyes. The correct answer is option 2, a Scandinavian client with freckles and blue eyes. Individuals of Scandinavian or Celtic descent typically have very fair skin, freckles, light-colored eyes, and often blonde or red hair. Because they produce less melanin, they lack natural ultraviolet radiation protection. Their skin burns easily, tans poorly, and is more prone to DNA damage when exposed to sunlight. Freckles further signal increased melanocyte activity, marking heightened vulnerability. Malignant melanoma, while less common, is highly aggressive and responsible for most skin cancer deaths due to its metastatic potential. Other risk factors include living in sunny climates or high altitudes, experiencing multiple blistering sunburns, having numerous atypical moles, and possessing a family history of melanoma. Nurses must stress protective strategies like broad-spectrum sunscreen use, avoidance of tanning beds, wearing protective clothing, and regular skin checks. Moving on to the incorrect options, let us start with option 1, the African American client with dark skin and dark hair. This group has a lower overall risk because darker skin contains more melanin, which provides natural protection. However, melanoma can still occur and is often found in less sun-exposed areas, such as the soles of the feet or nail beds, presenting as acral lentiginous melanoma. The key issue is late detection, not the highest risk profile. Shifting to option 3, the Mexican client with tan skin and dark brown hair, we see that while melanoma risk exists, higher melanin content lowers susceptibility compared to fair-skinned groups. These individuals tan more easily, reducing the risk of DNA damage from sun exposure. Lastly, option 4, the Caucasian client with brown hair and brown eyes, does carry an increased risk compared to darker-skinned populations, but the presence of darker eyes and hair means greater melanin protection. This profile is not as high risk as the fair, freckled, blue-eyed Scandinavian client. For NCLEX insights, remember the ABCDE rule: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolving changes in a lesion. The most common melanoma subtype is superficial spreading melanoma, and the most important prognostic factor is Breslow thickness, or depth of invasion. A test-taking tip is that the NCLEX often points to the fair-skinned, blue-eyed, freckled individual who burns instead of tans as the hallmark high-risk profile. Stancoast, Pearl. Always remember that melanoma risk rises where melanin is lowest. Think of the freckled, fair-skinned, blue-eyed client who cannot tan but burns easily. That is your NCLEX classic high-risk case.